PCR, then you'll have the quality billing PCR. So hopefully that makes sense. It's kind of the one thing that I want to push as much as I can, because it does. I think that a lot of times people at the operational level just they get tired of hearing billing this, billing that. And so if they just understand that we care about the clinical piece, then it makes it a little bit more palatable. So I wanted to show you guys a couple of things about quality documentation. It's kind of broken out into 3 sections. The first being demographics, pretty straightforward: patient name, mailing address, date of birth, etc. So we need to get as many of the demographic pieces as possible, just so we know that that patient is the patient that was transported, and that patient is the patient who should get a bill. We have, you guys may be surprised to hear there's a lot of Jennifer Joneses out there. Kind of weird. It's not such a common name, except Jennifer and Jones, pretty darn common across everywhere. In fact, I think I'm down in Pueblo. I think we've got like 3 people down here with the same name. So trying to get some additional pieces of information on the demographic side is really important, so we can ensure that the patient we're talking about is truly the patient we're talking about. Then, of course, you go into the clinical information. Why was the ambulance called? How was the patient found? You want to do the H&P. You want to make sure you've got your impression in there, all of your treatment, how they responded to your treatment. And then, of course, the transfer of care, whether it's to the hospital or, let's say, the nursing home or something along those lines. So again, the clinical information, good quality clinical documentation is going to solve the problems for billing. The other piece that is really important from a documentation standpoint are the signatures. We cannot expect a patient to have their benefits met or have their insurance billed or anything along those lines if we don't have a patient's signature. So the patient has the relationship with the insurance company. And since they have that relationship, they have to allow us to bill on their behalf. And that's why a patient signature is so important. If you get a representative signature, okay, that's fine. It's the second best thing to do. But if you don't get either of those and all you get is, let's say, a facility signature, then it's a big issue. We have to send a form to the patient to make sure that the patient signs. Then we have the ability to bill on the patient's behalf. So getting that patient signature after you've transported is really important from a billing perspective. And if you guys have questions, just interrupt me. And I can't quite see you guys like I could because I got this screen up, so I can't tell if anybody's raising their hand. So just yell out. Okay, thank you. The patient care record, the one thing that I like to always say, first we've got the clinical documentation. Quality clinical documentation is quality billing documentation. And then I like to tell everybody that the patient care record is actually the receipt or the statement for the services that we provided. The PCR is the billing record. That is what we use to bill out the trips. So you have to make sure that that quality clinical documentation is being done on that PCR, so that that billing record, the PCR, can be used to actually effectively and efficiently bill insurance or whatever the payer is going to be. So just remember that it's the statement or the receipt. I can never decide which one I want to call it, but either which way, it's that document that tells everybody what you did for that patient, and then we can proceed with the billing piece from there. So once the PCR has been written and posted or transmitted or submitted, however, whatever naming convention, we've got so many different ePCR platforms out there now that everybody uses a little bit of a different terminology, I guess, when you're actually talking about when that trip is actually finished. But this is going to really kind of delve into what you want to look at before it gets to billing, but after it's been transmitted by the crew. So some of the things that you want to look for are volume of trips. How many trips did you run in a month? And does that number of trips reconcile to the number of PCRs that you have? So you need to know your volume for obvious reasons. That one seems to be pretty straightforward. Doesn't really only apply to the billing piece. It's all encompassing for everything that you do, is knowing your volume. But then you do have to reconcile to the PCR. So making sure that we have one PCR for every patient contact is expected. Now, obviously, I don't know all of your medical directors. I don't know what rules they've got in place for what they want as it relates to getting dispatched to something. All I can say is if they have a patient contact, if a crew has patient contact, there should be a PCR. But again, if your operation or your agency does things a little bit differently, then stick with that. Don't think that just because I'm saying this is how it is, that's how it has to be. But in our organization, that's the case. For every patient contact you have to have a PCR. And then, of course, that PCR has to be posted or transmitted or submitted or whatever to get to the billing side. Again, I just want to reiterate the reconciliation of the PCRs to the CAD records. It's just important to know that dispatch said, okay, you have 5 calls in this last hour, and then you look and you only have 3 PCRs that have come through. Well, where are the other 2? Are they almost finished? Have they not been started? What's the scenario there? And making sure that ultimately we have a 1-for-1 match is what you're going to want to have ultimately, especially when we're talking about the billing side of the house. Authorizations and medical necessity certifications. These are pretty much for all your non-emergency transports. So if you're taking a patient from a hospital back to a SNF or something like that, you're going to need to get this medical necessity certification, also known as a PCS or physician certification statement. You may have to get authorizations on those IFTs when it's a Medicaid patient. So just knowing the different documents that you may have to have is important because that's how we're going to be able to bill that claim quickly and easily and not having a problem with losing that reimbursement if you didn't have those documents. I do want to point out, because I think this gets confusing at times, the medical necessity certification, which, as I mentioned, is also known as a PCS, is something that's federally required for any non-emergency transport of a patient with Medicare. So if the patient has Medicare and they're being transported non-emergently from a facility that they are under the direct care of a physician, you have to have that medical necessity certification before you can file a claim to Medicare. So, I've run into problems where the hospital says, well, we don't have to do it for ambulance agency B. And I'm like, but it's required across the board for everybody. So people may do it a little bit differently, but either which way, you have to have that form before you can actually bill Medicare. We already hit on patient signatures, but just to reiterate, the patient signature is the one you want to get. I tend to do it when the transport is over. So, we pull up to the hospital or to the nursing home or whatever, and my partner's getting out, walking around to the back, and I'm asking the patient for a signature at that time. It's the easiest time to do it. We're attesting to the fact that the patient was transported in the first place. And then we're also asking that patient for their authorization to bill their insurance or whatever payer they may have. Again, if you don't have a patient signature first, make sure you've got good quality clinical documentation as to why the patient couldn't sign, but then hopefully get a valid representative signature. And if they aren't available, then you would get a facility signature. Facility signatures are not super helpful. The only thing that they do is attest to the fact that we did in fact transport the patient to that facility. So it's important for that piece of it. But if we don't have a patient or representative signature, in order to bill that patient's benefits or their payers or their insurance companies, we have to send them a form that then asks for their signature and has the verbiage saying, hey, is it okay if we bill your insurance? So patient signatures are hugely important from a billing standpoint. So just making sure you're getting that patient signature is the ultimate way to go. Another pre-billing metric that you want to look at is the amount of time it takes to bill that trip once it's been sent to billing. So we actually look at about a 5-day window from the time billing gets the PCR to the time that it gets sent to whoever the payer is going to be. So on average, you'll see it around 5 days. And that's because, billing has to, they have to do investigation on insurance and make sure that they check eligibility. And then they have to do whatever, make sure you've got the PCS or the MNC. There's lots of little things that the billing group has to do. So it usually is around 5 days. Ideally, it's lower than that. But if you're above 5 days from the time that the trip gets sent to billing, then you might want to look at some different things and find out if there's something else going on. Do we have a system issue? You know, what's happening if it's more than 5 days? But on average, it should be around 5. The other thing to look at on the pre-billing side of the house is that charge per trip. This is literally the charge. This is how much you are going to bill for your services. It doesn't mean that it's how much you're going to get. That would be net cash per trip. This is the full-blown gross amount total charge that you're going to bill that trip at. It's broken out by different levels of service. You've got your ALS, your BLS, SCT, and so on, but you also have emergency and non-emergency. So all of these things come into play. They have to get broken out. It has to be, has to actually match up with the care that we've provided, the transport we've provided, and so on. So the other piece in Colorado, and I believe it's up to you guys on how you want to do it, but in general, you can bill supplies and procedures in the state of Colorado. Again, if you guys want to bundle bill, I think that's up to you. I can only speak to AMR, and we do itemized bill in Colorado. So if you want to go down to that level, that's fine. You just have to know what you want to charge for the supplies, what you're going to charge for the procedures, and also recognize that even though you've got it, Medicare doesn't care. They think that's cute. I like your bill, but they don't care. So they're not going to reimburse you for that. But you do have that option if you are interested. And double check with your billing company also, because as I mentioned, we bill itemized in Colorado. I think you have the option to do that, but double check with your billing company. So payer, oh, go ahead.
Go ahead, Jim. So I have a question for you. Number one, even when you think about billing in Colorado, how do you determine, obviously Colorado Medicaid is simple, but how do you determine a state administered plan from a ERISA plan?
I am so sorry because I can barely hear what you're saying. So just say it one more time.
He's asking how you can tell the difference between a state administered Medicare, Medicaid, and an ERISA plan.
So a lot of times that's going to come on the back end where you're doing some eligibility checks and trying to find out, okay, is this a straight Medicaid patient or not? So, and I do not personally do any of that investigation. So I would have to ask my supervisor who does manage all of that work to find out exactly what they're doing to make that happen, to differentiate between the two. But usually it comes through eligibility checks and just double checking for benefits. I don't know if that helped at all.
Thank you.
Any other questions? Okay.
So,
oh,
talking about building and you're getting ready to go into payer mix. There's some schools of thought.
Okay.
Schools of thought are, should we be delaying our bills to insurance so that other providers, such as the facility, takes the deductible and copayment hit, and so we're theoretically maximizing our return on our billing.
Right. Yep. That's a great question, and certainly something that has come up in the industry a lot more in the recent years than it was ever thought of 20 years ago. But that is a thing, especially, I hate to say this, but especially the first of the year. I just went and got a prescription. It was $0. I was like, I love this time of the year. I can't believe it's almost January, because as you guys know, January, everything resets, and that's for our patients too. So there are some processes out there where you can manage the deductibles and kind of do a deductible hold. It depends really on how you as an agency want to process that billing. But it is something that's really come up lately, and something that I think does get practiced in many areas. We talk about it on our side, trying to figure out how we want to manage those deductibles early on, especially early on in the year. But it is something that I think should be considered, because it is a thing.
And I have another question.
Okay.
Another question is, should we be prioritizing some calls over others? For example, Colorado does have MedPay for traffic accidents.
Right.
Uh, Should we be prioritizing and getting those bills in to the casualty companies? Because the hospitals are really good at getting their bills out to the casualty companies quickly. And even when I've seen some EOBs come back to me from the casualty company that says, sorry, but the med pay has been exhausted. So
Right.
we'd be potentially, because if the alternate payer is like Medicaid, we just missed out on a lot of money.
Yep, exactly. That's a hard one as it relates to prioritizing. I think you kind of have to make an agency decision on how you want to handle that. I agree with you. And I do get frustrated too when we get the EOB and they're like, oh, too bad. Sorry about that. So I think it's something that you have to consider because you want to be able to get in there with the med pay stuff before it's all used up, basically. And so again, I think it's an agency related, how do you guys want to use it or do it at the agency level? Because I think people do it differently across the board. And I know that was a seriously great answer for you. Any other questions? Okay, we're moving on to payer mix. So again, we're still talking pre-billing metrics. And again, these are just the things that you should be looking at before we really get to the reimbursement side of the house. But knowing your payers is really important because they're going to have different reimbursement rates. So Medicare, as you guys know, everybody says it, their reimbursement is terrible. It's just a terrible reimbursement from Medicare, and Medicaid's even worse. So you want to know how much Medicare you have in your market, because that's going to help make sure that what your actual net cash per trip, it's going to make more sense if you've got a primarily Medicare system. So just knowing what the rates are is really helpful. And this is a national snapshot for AMR. And so you can see over the last year how everything's kind of looking. And so right now for Medicare, we've got just about 45% client base basically for Medicare. So just knowing that is going to help you understand your net cash per trip a little bit better. Level of service mix is also important. And this is basically trying to figure out, okay, how many advanced life support calls did I have? How many BLS calls did I have? And again, this is a national snapshot. And you can see here that we had about 58% ALS across the country. So again, just knowing that is going to help determine what your net cash per trip may be, and actually your charge per trip also, because they all have different rates. So and I think I've got it in another slide actually for after the billing. I'm going to wait and we'll get into it on the next section. Any questions here? Okay. So now we're going to look at what happens. What do we need to monitor after that trip is billed? So your days sales outstanding, so your DSO, is a really important thing, especially if you're looking at your budgets and trying to figure out, okay, we need to do this next month. We need to buy now the LifePak 35. I can't believe that. I don't know what happened, why they went from 15 to 35. I'm not sure what that's about, but I haven't used the 35, but it's pretty darn cool. Anyway, side note there, but you want to know what your DSO is so that you know when you're supposed to have cash coming through the door. The DSO is the average number of days that it takes to get paid from the date of service. So if I was transported today, it would start from today until my bill was paid for. That would be the DSO. If you do have a shorter number, as you can see here, mid 70s, 75 days or so is a pretty standard day for DSO. So if you're looking at it and you've got a 50-day DSO, then you may have a very efficient billing process. I would still investigate a little bit just to make sure it is efficiency that's driving that number down. But sometimes, it's just, oh my gosh, that person's getting the claim out the door within a day. And as you noticed, we have a 5-day window before we get the claim truly out the door. And so if this person's got a 1-day window, then you may have a better DSO. So just kind of keep an eye on that. If you go over, let's say 75, try to figure out what's happening, because obviously that's not a good number. That it's going to slow the reimbursement. It's going to slow the cash coming through the door. So you just want to investigate what's going on if you're veering from the mid 70s. And then realize, of course, that it's going to vary by payer. Medicare may not pay us very much on the dollar, but they actually respond with either a payment or a denial within about 14 days once they've got the claim. And I put in here clean claim. That pretty much means they have everything they need. There's no, they've got a middle initial and they know the birth date, and sure enough, they've got the social security number. And actually, we even have the Medicare number. If you have everything, you can see some sort of response from Medicare within about 14 days. So that's pretty cool if you can get that turned around. But the commercial and the private pay, they take much longer. If you guys have to deal with VA, you know that VA is a nightmare and it takes a long time. So it's going to vary by payer, but you want to see it sitting in the mid 70s. And if it's outside of that, then just do a little investigation and find out what's happening. Okay, your net cash per trip. We talked about your charge per trip before the bill was put out, but now your net cash per trip is something that you want to look at, because it's actually the amount of money that you received for the transport. So let's just say your ALS base rate is $1,000, but Medicare says, okay, that's nice, but we're not paying you $1,000. We're going to pay you $400. So you can see that our charge per trip was $1,000, but our net cash is $400, because that's what Medicare is going to pay. So it's going to depend on your base rates. So your base of ALS, BLS, and so on. It's going to depend on whether or not it's an emergency trip or a non-emergency trip. And as we talked about, whether or not you bill ancillaries. So all of that comes together to help form that net cash per trip. And then also remember that payers have a different allowable by payer. So Medicare is going to have its own, Medicaid's going to have its own. And so the allowables don't come in across the board as one number. It's always, 15% or whatever. It doesn't work that way. It's whatever that payer thinks their allowable should be is where it comes from. So look at your net cash per trip by payer. It's really helpful if you can look at that, because again, if you see something that's weird, then you can start to address it. Over here, you can see that the overall net cash per trip is usually about 60% of the expected payments. So that's not great. It'd be wonderful if we had, 90% or something along those lines, but usually it's about 60%, and that includes private pay. So looking at your private pay numbers, looking at your commercial payers, look at all of these different areas and see how well your net cash per trip is for that payer, because then you can start to figure out if you need to do something a little different. Do you have a contract that you need to reach out to? Do you need to go to that facility and find out what's going on? Does Medicaid have an authorization that you're supposed to get, but you weren't getting it because you didn't know you had to get it? And is that causing a problem? So just look for all of these little things that cause some sort of deviation from the numbers. Your AR over 90 is that total balance of outstanding dollars for a transport that is over 90 days old. So again, 90 days from today, the 17th, let's say I have that $1,000 bill, got paid $400, and let's just say that it's not all, allowables and all that stuff. They're still expecting me to pay $600. So the total balance right now that's outstanding is that $600. Again, this is just hypothetical. It's not realistic, but it's $600. And if nothing gets paid on that $600 from the date of service plus 90 days, then you're going to have AR over 90 that you need to look at. It is a problem. If you have more than 40% of your claims that are over 90%, 40% of the total balance outstanding over 90 days, then you might have a billing problem like the authorization thing that I was talking about. We run into problems where Medicaid changes their program and now they require a prior auth instead of a retro auth. And we didn't know that. And so all of a sudden we had all of these trips that are sitting over 90 days because they weren't getting paid because Medicaid was waiting on an authorization that we didn't have. So that could be the problem. One of the big problems that we're seeing right now are checks going to the patient. So most of the really big insurance companies and also insurance companies that are out of network, meaning we're not contracted with them, will send the check to the patient and expect the patient to then pay the bill. Unfortunately, that doesn't always happen. It's a check coming to you and, oh, good, I needed, another $100 for whatever. And so if the patient doesn't send in that check, then you may be looking at stuff that's sitting out there greater than 90 days, but you can start to find out what that reasoning is. And then maybe you're calling the patient and saying, hey, according to our records, you have Blue Cross of wherever, and they indicated that a check was delivered to you directly. So it's just something that opens your eyes, helps give you more information on what's happening, and then you can actually monitor and manage your AR over 90. Any questions? All right. So still in the post-billing metrics here, you want to do audits of anything that is zero pay. So you've received nothing for the last 60 days since the date of service. So again, 60 days out from October 17th, if you haven't seen anything, no payment whatsoever, the patient has insurance, that the patient has Medicare, but for some reason we haven't gotten paid, you need to find out what was going on. And really, so 60 days out, okay, you're given some leeway there, but it's really good to look at things even 30 days out and just try to figure out, okay, why have we not seen any movement at all on this claim? And again, if Medicare is going to pay in 14 days, you shouldn't have to be looking at a Medicare claim that's 60 days old. So just pay attention to it, look at it, find out what's happening, and then you can actually start to dig into some of the details. Of course, the beginning of the year, kind of like we were talking about, it's January and the patient is transported and they've got a big deductible that hasn't been met yet. So the payment went to the patient's deductible. That's a big reason. Again, the check to the patient, it has really become a thing. I don't quite know why all of a sudden it is so big of an issue, but it's really an issue. I don't know if you guys are experiencing it, but it's kind of coming to haunt us a little bit. So hopefully you guys are having better luck in that category. If we don't have demographics so that we can send the bill to the payer, then it's a problem. Great example of that is all the Jennifer Joneses out there. And if they don't know my social, they may not know who's actually the patient for that trip. So they may not be able to bill that claim, or maybe they bill the claim, but it's not actually going to get reimbursed because they don't have the correct information. And then, of course, no medical necessity or a non-covered service is going to be a reason for not having anything over 60 days or so. I think we're going to hit a little bit more on the medical necessity in a few minutes, but I wanted to just mention that there isn't a good hard and fast number on the zero pays because it really is market driven. So however your agency is, is it a large agency? Is it a small agency? Are you primarily Medicaid? Do you have a bigger private pay contingent in your area? It's really going to depend on how things look. So the best thing to do in these cases, in my opinion, is you go back a year and see what your numbers were looking like, and then do some investigation, see if, you're having problems because all of a sudden Blue Cross is sending the checks to the patient, and then just try to figure out where you can make improvements. I'd love to give you a number, but it's impossible with all the different dynamics of all the agencies. Okay, billing for denials. So this kind of gets back to this no medical necessity or a non-covered service. Billing for denials for Medicare patients means that we're billing the trip with a GY modifier, and GY means, hey, Medicare, we are not requesting reimbursement for this trip. We don't think it's medically necessary, and as a result, we don't want you to pay us. So you guys may be sitting there going, why would we do that? Well, the reality is there are times where it's not a medically necessary transport. We all know it. We've all had it. It's happened. Sometimes the sniff to the hospital, it's like, okay, I think they could have gone by wheelchair van. Oh, it's 2 a.m. and the wheelchair van's not running. So that's why we took them by ambulance. That's not a reason for ambulance transport just because the wheelchair van isn't running. So if that transport is not medically necessary, or it's not covered, like a transport to a physician's appointment, then we're going to bill for denial. We're billing still, we have to file a claim because there were services that were rendered. So we still have to file a claim. We're just not asking for reimbursement because we don't believe it was necessary to go by ambulance. So I want to make sure that everybody kind of gets that GY modifier thing, especially on the Medicare side, because that is another one that's really hard to say what your rate should be. In some markets, it might be less than 1% of your trips. In other markets, we've seen it as high as 10 or 11% of your trips, but it's totally dependent on the market. It really is about the kind of transport you have. Are you an exclusive 911 provider? Are you very rural? I mean, you have to look at all of the different pieces that come together to make up your market to determine what your GY number should be. GY, we bill not medically necessary for Medicare and some Medicaids as well. It's a government payer scenario. So usually your commercial insurances, you don't have to worry about the GY stuff. But it is something that we do have to manage on the government payer side. Also remember that if you bill GY because you didn't find that transport to be medically necessary, and the patient also has Medicaid, the trip gets written off. We cannot bill a patient who has Medicaid the bill if we billed for denial in the first place. So, unfortunately, Medicaid, we can't balance bill a Medicaid patient usually. So it's one of those things that if the transport's not medically necessary and they have Medicaid, it's just unfortunately a lost revenue trip. And it happens, especially in those markets that are exclusive operating markets. If you don't have a choice, they called and what are you going to do? You're going to tell them no. And that changes the dynamics of the community and how everybody feels. And it just gets really ugly. So everything's a business decision in your market, but just realize that there are reasons that an ambulance is not necessary. And when you have those, you just have to deal with them. Also, a lot of people don't know, but there are 911 calls that are not medically necessary. Most people think that if someone called 911, then automatically it's going to be a medically necessary transport. Not the case. You can think of all of the different times that, the nice lady is sitting on the sidewalk with her suitcase and she's smoking a quick cigarette and you're like, okay, you want to go to the hospital? And she does, but there's no clear reason why. And so in those cases, it may not be medically necessary. So don't think that just because it's a 911 call, we can bill it. Just realize that there are going to be times where if it's not medically necessary, it's not going to happen. This is where I want to go back to good quality clinical documentation. Is clinical documentation leads to billing documentation. So if you've got good quality clinical documentation, the billing should come easily. And I bring that up here because one of the problems we run into is that medically necessary transport that we're saying, no, we can't see why they went by ambulance. Sometimes it's a function of having really poor documentation. Meaning, your crews are running back to back to back calls and they're down on paperwork and it's a nightmare and they're trying to get off shift. And so they're just writing their charts as fast as they can. And they forget to write about the history of what's going on. And they forget to put in the pain scale. And they didn't write down all of the medications and they only took one blood pressure. So if you've got weak clinical documentation, then it's going to be weak billing documentation. So just keep in mind that there are definitely patients who we don't have medical necessity to transport them, but it also could be a part of the documentation where the crew was running so quickly and not documenting well that may have made the chart look like it was not medically necessary. So just something to keep in the back of your mind. Good clinical documentation will be good billing documentation. And unfortunately, I have to say this, and it kind of makes me mad that I have to say this, but we're talking about honest and accurate documentation. I don't want to hear that somebody's like, oh, well, good quality clinical documentation is good quality billing documentation, so I'll just add this, this, and this. No, you do a good clinical PCR based on what you're seeing, based on the entire situation, all of the treatment that you've provided, et cetera. And when you can paint that clear picture in your PCR, then the clear picture is going to be present with the billing coders. Acuity is one thing that has come up maybe in the last year and a half, maybe 2 years. But Brian Werfel from PWW actually indicated at one point, it was a conference our compliance people were at. I don't remember the very specific details. All I do know is compliance came back and said, huh, this is interesting. But he basically said that you shouldn't have more than 85% of your emergency calls as ALS. If you have more than 85% ALS emergency calls that are billed out as ALSE, then you need to look at what's going on. It very well could be that it is completely accurate. It just happens to be the type of market that you're in. And sure enough, every time we look, we've got 86% of all of our trips are ALSE, and we've reviewed them and reviewed them and reviewed them, and it's legit. And if that's the case, that's the case. It's not a big deal. But his theory is that in general, it shouldn't be more than 85% of the time. So just keep an eye on your charts, make sure that things are falling where they should based on the market that you're in, and just ensure that really the documentation is quality, and then the billing that's following through with that. So I thought that was an interesting number. Anybody have any thoughts on that? Okay. Write-offs and bad debt. So write-offs are just miserable. I hate them. This is another thing where, you guys are going out there and you're providing a service, you're trained, you've got quality clinicians who are out there who had to go to school to become a clinician, and they're doing everything they can to help these patients, but it still gets written off. Some of it could be documentation related. And if that's the case, then you work with your crews, make sure they understand what good quality clinical documentation is, and then try to figure out how you work through the back-to-back-to-back calls and having to get paperwork done, because that plagues all of us, unfortunately. Demographic problems, if you're missing an address, let's say we send the claim to the patient, it's private pay, send the bill to them, and it gets kicked back to us because we had the wrong address, or it didn't get kicked back to us, but it also didn't make it to the patient. And the next thing you know, you've got 120 days of a zero pay trip, and you're like, oh, shoot, now what? So it may be leading to a write-off. So work with the facilities to try to get face sheets, updated face sheets. The other thing that we're working on is trying to get access to the hospital systems so that we don't have to bother the admissions clerk and say, hey, can you give me that face sheet for Jennifer Jones? And then she says, which Jennifer Jones? And you're like, ugh, Jennifer L. Jones. And then you go through that thing. But anyway, if we can actually work with the facilities to get those face sheets without having to bother people, they really appreciate it. So getting updated information from the facility is really helpful. And then, of course, making sure the crew knows the importance of making sure we've got good demographic information. There are things that are non-covered. I mentioned earlier, if you have a transport that the patient was just going to their doctor's office, it's going to be a non-covered service. So what do you do with that? Well, maybe we talk with comms and say, okay, when we have these calls, let's really screen the call, see what's going on. Does this patient need to go by ambulance, and so on? Again, if you're an exclusive market, you may not have a choice. And it's a business decision. You have to do what's right for your business and also do what's right for the patients. But in those exclusive markets, it may be a little more difficult to work with comms and say, oh, this guy's going to the doctor. Who's going to take him if we don't take him? So it's kind of a hard place to be in. But doctor's appointments, they're non-covered. Patients who are strictly bed confined, that's not a covered service. So I can get you guys a list of non-covereds if you'd like, but you can also go to cms.gov and get that info. Missing authorizations, we kind of touched on it just a tiny bit earlier. You have to get authorizations for Medicaid transports. And occasionally another payer, maybe a Medicare HMO, or even we're starting to see some of the commercial payers requesting authorizations, which I hope that doesn't grow legs, because that could be a rough deal for all of us. But missing authorizations can lead to having to write off that trip. If you have to get a prior authorization before you even think about running that ambulance, then you better get the prior auth. And sometimes the Medicaid broker will work with you. Oh, it was after hours. Okay, we'll work with you. But sometimes they just won't. And you are just SOL in some of those cases. So know what the requirements are for your different payers. And if they require authorizations, find out when you have to get that authorization. And you also should find out who needs to request it. We have a lot of places where we, as the provider, are not allowed to request the authorization. It has to be the sending facility who does it. That's in different markets. Colorado is not that way, but just make sure you know what the authorization requirements are so that you don't run into having a lot of trips that end up getting written off. And also, I'll say along the same lines of the authorization, make sure you're getting newsletters and so on from the different payers that are out there, because they do make changes occasionally that don't get caught right away. And when they don't get caught, then you end up having, months worth of trips that don't get paid. And then you go look at it and find out, oh, it's because I didn't have the authorization. So just make sure you're really investigating what your payers require so that you don't run into problems and have to write off bad debt. And then this last bullet says bad debt is usually driven by private pay. Private pay is the hardest. I think that's fairly self-explanatory, but our private pay issues are really the ones that lead to bad debt. And your write-off should be less than 12% of your total gross numbers. So, again, it'll be somewhat market dependent, but ideally you should be less than that 12%.
Hey, Jim,
Yes.
12%, that's bad debt. That does not include contractuals.
Correct.
Okay, just making
Correct.
sure. Thank you.
Yep. Mm-hmm. And actually, now it's time for any questions you guys may have. I got to pull you down here so I can see you. All right, any questions?
Tim.
How do you handle appeals, or how
Oh.
do you, like an insurance underpayment? And how much do you have to get the patient involved in processing an appeal to an insurance company?
Great question. It kind of depends on the payer. So we have a third-party vendor who does our billing. We in-house manage all of our government payer appeals. So for us, we try to take care of it. We don't want to have to get the patient involved if we can help it. Because one thing I didn't mention that I know you guys are well aware of, but billing is patient advocacy too. And I always tell people that just because you drop the patient off at the receiving facility doesn't mean you're done. That patient has to be advocated for all the way through until that bill is paid. So if we're on the back end and we've got poor documentation, well, that's not solid advocacy for our patients. So we may need to get them involved. We may have to ask them to get their PCP's notes or something along those lines. But we, as a company, try as much as we can to not have to pester the patient, because they've already experienced some sort of trauma by having to ride in an ambulance to begin with. So we'll do what we can to work the appeals. It does depend if we get a denial or like, no, seriously, this one shouldn't have been denied. Then usually our billing vendor will send an appeal. But to answer your question about how much to get the patient involved, we try as much as we can to not have to worry about that for them.
To identify when you get an underpayment, or how does your billing company identify when they get an underpayment from an insurance?
So that's another good question. I don't even know the best way to answer this other than they have multiple pockets of coders who handle different pieces, and the people who handle the AR on the back end. When we get a cash check or something, we do cash posting and they see that it's an underpayment, then they go back into the trip in the account and try to figure out, okay, why is it underpaid? They may reach out to the insurance directly, but a lot of times it's a situation of just trying to ask the insurance company why, what's the reason behind this, especially if the EOB doesn't make any sense. So it's frankly, it's a lot of communication, and it's just pockets of people who do different different duties within the billing company. Other questions? One thing that I was thinking about, we're talking about appeals and so on. If you have a facility or a patient or somebody, the chart was billed with a GY modifier, so we billed it for denial. If you've got somebody who contests that, we have a department within the company that reviews GYs that have come out as, you know, a patient doesn't agree or the facility doesn't agree or something along those lines. So we actually review those internally. If you can get hospital documentation, discharge notes, ER notes, whatever the case is, when you can get that additional documentation that paints the picture of how that patient looked at the time of discharge, then sometimes that additional documentation is helpful with an appeal. So we do a lot of GY appeals if we get that additional information. And many times the patient has no problem trying to find that documentation for you. And the hospitals usually don't push back too much either. So again, it's worth having as much information as you can possibly have. Again, the clinical quality documentation is going to help, but sometimes you have to get some additional help from facilities.
And last but not least.
Go ahead, Tim.
So based on a previous presentation, tying what our billing codes are versus the ICD-10 codes,
Mm-hmm.
that clinical impressions, is AMR looking at that, tracking that to make certain that the clinical impressions, the ICD-10 codes based on clinical impressions match the level of billing that you're sending out? Based on,
So I'm sorry, I didn't mean to cut you off.
based on like ALS, ALS2,
Mm-hmm.
all that.
Yes. So again, and I'm sorry because it is a third party billing company, so I may not be able to give you as much detail, but it's kind of funny that you brought this question up because obviously with NEMSIS 3.5, we've had to really work through some of the data challenges because they changed a lot with primary impressions. Used to be pretty straightforward with primary impression, and now it's got all kinds of stuff. So what happens when our trips go to the billing company is obviously they're electronically delivered, and there are rules within the system where the impression comes over. It's actually crosswalked to an ICD-10 code, and then it hits the billing company's system, and then they can see what that ICD-10 code is to begin with. So they do go back. There's two reasons they do. So they'll look at what it is. They'll compare it to the PCR, make sure it makes sense, make sure it's not off the wall. But the other thing that they'll do in some cases, some of the Medicare payers, some of the payers in general require certain codes. And so they may not allow you to have this code. You can't submit a claim with these codes. You have to submit claims with these specific codes based on what is most appropriate for that patient. So if you've got something along those lines, then you have to follow that guideline. But yes, our billing company does look at the impression that's coming over, how it gets interpreted in the system, and then what's appropriate. I hope that answered your question.
Okay, you've got one in the chat from Corey.
Okay.
How do you handle dealing with duplicate claim denials when the duplicate is caused by company one cannot do the transport and asks company two to take the transport, then company one bills the patient insurance? This applies to interfacility transport.
Okay, that's for interfacility. That's an interesting question. We see a lot of that stuff with intercepts. That's probably our bigger issue than some of our interfacility stuff. We have a lot of flight team transports too. I'm sure you guys do as well. And it depends on essentially who's set up to be able to do the billing. So we'll transport a flight team with the patient. And because we are the ones with the wheels rolling, we're the ones that are going to actually submit the bill. And then of course, maybe there's an agreement with the flight company, and then they're getting reimbursed, or maybe the hospital's getting reimbursed because we're doing CCT. Although I think that's kind of old school now, because it seems like you don't have to worry about that as much. Anyway, so duplicate claims can be really difficult, and we do run into those here and there. I can't give you a commonality with the duplicate claims that we experience, but it does happen sometimes. And it gets back to the whole investigation and appeals, and we have to write letters, and we have to make sure we're working with the other company that billed the trip if they weren't supposed to bill a trip. And most of the time, it's just contractual agreement with that other company. I know that didn't answer your question on that one.
At what point do you go to collections?
Oof, that's another good question. If I had my way, it would be virtually never, but obviously I don't get to say that. It depends also on the payer. It depends on communication with the patient. It depends on a multitude of different things. We usually try to keep out of collections as much as we can, because it's just a bummer to do that to anybody. Nobody wants to be in that position. I don't know what the current day range is right now. I know we had a very shortened timeline probably a year ago, and it was actually causing more problems because it was such a short turnaround. So they've extended that time frame, but I couldn't tell you exactly what that is anymore.
Oh, Tim's got one more for you.
Okay.
That you use, which kind of surprises me that GMR would use an outside billing company. I would think that you would manage that yourself. And then some of the information that you've already provided, like bills over 90 or all that stuff. If you were to audit your billing company for clients, if you could give us 3 examples of issues you would look at or you would want to pay attention to as the customer of the billing service, what would those be?
That's a really good question. A couple of things. First, we used to do in-house billing, and it's a thing. And so for you guys working with your billers, whoever's doing your billing, you know it's a headache and a half. So I think it was 2014 that, or maybe, no, it was 2014 that we moved to an external vendor. We do have various metrics that we try to monitor with our billing company. For obvious reasons, we want to make sure that they're doing things the way that we expect them to do things. And of course, compliance is a big deal, and they work very closely with our compliance department. They have a very robust compliance department themselves. So there's different things that you can look at. You know, DSO is always kind of the big thing. How long it takes for that trip to actually be billed once it hits their hands is another big thing. You know, we just have a variety of, even the GYs, we would look at the GYs to see what the numbers are. Really, the stuff that I have in this deck are probably the biggies that we look at, because they tend to lean toward better reimbursement when the numbers are handled correctly, when they're being worked as expected, when the policies, you know, are being followed, then everything seems to come in line. It's when the policies don't get followed or somebody misinterprets something, and the next thing you know, we're sending all trips back for a crew member signature. It happened. And really it's because a policy had changed and it wasn't communicated across the board. And so if you don't have that good communication, you're going to run into problems. So making sure you've got solid baseline metrics are really going to help you. And again, as I mentioned, the ones in this deck are probably our biggest ones that we look at.
One example that I might give you is, how does GMR know if their billing company is or is not on occasion like upcoding a charge? So you may send in something as a BLS call, and then it gets billed out as an ALS call, because the more money they generate for you, the more money they make, right? How do you know that they're not upcoding claims or downcoding for that matter? I mean, it'd be better to go the one way than the other, but how do you prevent, or what's your oversight for potential upcoding?
There is huge amounts of oversight. Again, on the compliance side, they work very closely with compliance. On the billing company side, there are audits that are done every month, sometimes even, we look at trips, our compliance team looks at trips all the time, multiple audits that get done all the time, whether they're internal compliance audits or even outside, Medicare audits that happen. It is constant oversight, looking for what's going on and making sure we don't have an issue. And I couldn't even tell you how many times there are PCRs that are reviewed just to make sure that everything looks good. So do accidents happen? I'm sure they do, but ultimately we do the best that we can to ensure that we've got good oversight and good compliance with the company, and we work really closely with them. There's no doubt in my mind that I have at least 5 calls a week with those guys on various topics, obviously. And that's me. The compliance team is even doing more than that. My boss is doing even more than that. There's just constant communication with them, and I think that's the key.
Have policies or check sheets that you follow that GMR may be able to share with a less fortunate group? I mean, when you have a whole compliance team, and obviously you've had the procedures that you're looking at the claims to follow.
Mhm.
Is there anything that GMR could share for the force for compliance? I mean, to help us be more compliant with our billing
Sure.
process.
Sure. That's a great question that I don't have an answer to. I would have to talk to my boss as well as the compliance team, and I'm happy to do that. I will definitely take that back to them, and then I'll get with Kim and let him know.
And now I will shut it up.
Okay, he swears he's done now.
I'll believe it when I hear it.
Any other questions in the room? Jen, I don't see any more questions online.
All
Thank you
right.
so much. And I hope you get to feeling better.
Thank
and,
you.
Back in touch with you.
Sounds
I presentation so that I can share that with the group. And I'll be reaching out, plus looking at this compliance check sheet. I think that's a great idea.
Yeah,
Thank you very
I'll
much.
definitely check on that.
Have a great day.
All right, you guys, thank you. I appreciate the time.